In the last episode, we told you how to diagnose correctly and how to approach vital pulp treatments. And now we will go more into detail and we will say how to do it in practice. Ladies and gentlemen, welcome to season 2 of Endocast, hosted by Ahmed Shauki. Hi, Ahmed.
Hi, Francesca. And of course, Francesca Cirutti.
So, the first step to make a successful vital pulse treatment is, of course, what you said in the first episode. So, to diagnose and to select the case adequately. And so, how could we do it? First of all, we have to speak to the patient and try to catch some details. So, for example, know how is the pain, for how long, when it presents, what's triggering the pain, in order to understand if that pulpitis is initial, mild, severe, and then do all of our diagnostic testing, of course. So the pulp sensibility test, etc. Take an X-ray, see how deep the decay goes into the tooth, and then, of course, try to classify in which stage that pulp is, because according to the stage we know that there are some suggested treatment that we can apply, and in this case we can determine which is the best option for this tooth. So maybe we can go with a direct pulp capping, or if the inflammation goes more into the tooth, we can opt for an example partial or a complete pulpotomy, or maybe we have to do something different, okay? But try to put in your mind that the most important thing in this case is to act in an environment which is as free as possible from bacteria. So a good rubber dam isolation is the key to have success, because we have to reduce as much as possible the bacterial load. And so if you are struggling in placing the rubber down correctly because maybe the tooth is destroyed and there is some leakage, try to recall all of those small tips and tricks that you can apply to the case in order to improve your isolation. So maybe use some liquid dam, use some pre-endo build-up, do something that can improve the adaptation of your rubber dam sheet to the tooth. Use some Teflon. There's plenty of tricks that you can use in order to make your isolation better. But this is a very important step in the vital pulp treatment. And then remember that if you feel disinfected, the prognosis of the VPT is higher. And then remove the decay, because you have to remove the reason for the inflammation. So you have to remove the bacteria. And now there might be some controversy in how much of the tissue you have to remove, because some schools will tell you to remove all the infected and affected tissue. Some other schools will tell you no, you can leave some tissue that is affected but not infected in order to be more conservative. This is up to you, but try to remove as many bacteria as you can. And remember that if you see the pulp, you have exposed it, you have to manage it somehow.
Yes, I totally agree about the bacteria because the worst enemy to vital pulp treatments are the bacterial leakage, because this will definitely lead to failure. And in this aspect, we need to highlight that from the beginning of your case selection, you have to differentiate between two types of lesions or disease categories. We have class 1, which is a very clean exposure, like those in traumatic dental injuries, and those class 2 or infected exposures resulting from caries exposure. So if we want to compare between both categories, the class 1, which is present mainly in traumatic exposures, whether a traumatic dental procedure exposure or traumatic dental injury, which has high success rate because there is no bacteria. And we conducted a systematic review maybe 3 years ago about the success rate of vital pulp treatments, irrespective of the procedure, but it's a vital pulp treatment in traumatic dental injuries, and we have 90 to 100% success rate of these clean exposures. On the contrary, we have a lower success rate when we have caries exposure, especially in class 2 decays or occlusive proximal decays because of the lot of interfaces and the possibility of leakage. This is very important because you will need this when you select your case and also to discuss with the patient the possible prognostic factors. We move to step 3. After the isolation, we need to select our approach in vital pulp treatment, as we mentioned in the previous episode, and you will start dealing with the tissues. First, you are dealing with the bacterial involved tissues, as Francesca mentioned in the previous step, and then you will deal with the vital pulp. So if you have exposure and this exposure is small, but it's still showing some bleeding that is not responsive to the usual hemostasis that we perform, like a cotton pellet with saline or a flush of sodium hypochlorite or a pellet soaked with low concentration sodium hypochlorite, and there's still some sort of minute bleeding coming from that exposure. So in those cases, I will move forward to a more invasive, a little bit procedure, which is enlarging the exposure in order to visualize the tissues better and maybe to remove part of that tissue from the exposure to do a partial pulpotomy rather than doing a direct pulp capping. And then you perform your hemostasis, whether with a sterile cotton pellet soaked with saline and press for some time, or with low concentration sodium hypochlorite soaked in a cotton pellet and pressed for 5 minutes, for example, or a flush, passive flush of high concentration sodium hypochlorite for a couple of minutes until you disinfect and stop any bleeding. If I reach hemostasis at this stage, so I will do my partial pulpotomy as we discussed in the previous episode. But if the bleeding persists from this enlarged exposure site, so I need to do a full pulpotomy because I need to remove the whole inflamed tissues, and then I will repeat my hemostasis approaches, whether one of them or two of them maybe, until I find hemostasis at the level of the pulp stumps. In this way, we go progressively until we reach the stage where that we have a healthy pulp tissue remaining inside. What comes next after the hemostasis with either of the three methods? We need to do the capping material or the place the capping material. Previously it was calcium hydroxide, or let me say traditionally it was calcium hydroxide, but with calcium hydroxide we have good success rate according to literature. But with the introduction of the new bioceramics, starting from the MTA to the pre-mixed forms of the calcium silicate cements, we have a higher success rate because of the quality of the seal provided by the MTA and bioceramics, which is by far better than calcium hydroxide. So now we can place a pre-mixed calcium silicate based material like the bioceramic putty, and we use the dedicated carrier to deliver the material over the pulp stump. Whether the pulp stump is an exposure for direct pulp capping or that pulp stump is a partial pulpotomy, or the pulp stumps are the at the orifices of the root canal, and then we leave the material and we protect it as you saw in the previous videos, and we protect it from our acids that we used in the restorative procedure, and then we can uh, go to the restoration and follow up. So maybe Francesca will summarize the restoration, because we discussed it in detail in the previous episode.
I have a question for you first. While reading about all these vital pulp treatments, I read that in a survey, many young people were found to use calcium hydroxide as election material for VPT instead of bioceramics. Do you think it's due to the education that they're receiving in the university, so maybe some old school professor teaching to use calcium hydroxide, or about accessibility?
Okay, I believe that many of the young colleagues are still using calcium hydroxide, maybe because of the education part, as you said, and maybe because of the know-how of dealing of the materials. They don't know that we have a lot of easy solutions with calcium silicate materials, and more important in practice when we're talking about comparison between calcium hydroxide and MTA is the price, because not all clinician can provide the MTA, although nowadays there are a lot of inexpensive formulations. So I think all the three are factors that can make some clinician prefer to use calcium hydroxide as a comfort zone in these types of cases.
Thank you.
Yeah, but I have to add, because many of them would see that discussion that we are running through, the quality of the barrier and seal provided by the calcium hydroxide is defective. It cannot be dependent for long term, because the barrier performed by calcium hydroxide or induced by calcium hydroxide suffers a lot of porosities, like the tunnel defects, and it is not of uniform density. It's subject to a lot of factors, while with MTA we have a totally dense barrier formed with no defects or porosity, and it is predictable in thickness, not unpredictable like calcium hydroxide. So this is very important, and why we use MTA, beside, of course, all the biological advantages for the calcium silicate cements.
We always said immediate restoration, immediate sealing of that area, because we don't want bacteria to be able to get in there and compromise all what we did with our treatment. And so a high quality coronal seal is mandatory. So if you can use composite, use composite. You can also use some mix between composite and glass ionomer, but still do not put provisional materials. Otherwise, you will lose all what you did before. And how do we follow up? Well, we do clinical and radiographic controls, as we do normally with the endodontic treatments. And so 6 months, 12 months, and then but a yearly base you can, or 2 year base, you can recall the patient and check. And of course you have to monitor the resolution of the symptoms, because in the first place you did the treatment because there were some symptoms probably, and you have to check the vitality of the pulp, the formation of new dentine, etc.
Yes, that's a little bit old case. It has more follow up, but that was the last follow up. It was a case in a young girl, and it was having no symptoms except that she's feeling cold sensitivity for a short time with cold drinks, no spontaneous pain, no throbbing pain. nodal aching pain. And when we took an X-ray, we found that we have an occlusal proximal decay. So we needed to just remove, and there was a restoration, occlusal restoration. So we removed everything, and then the patient. We find that the hemostasis was not predictable, and I cannot achieve hemostasis with a partial pulpotomy. So I decided to go for the more radical but yet predictable treatment, which is a complete pulpotomy. And the treatment was performed in a single visit with the restoration, of course, as you mentioned. And we followed up for 1 year. Of course, when we follow up total pulpotomy cases, we cannot do a vitality test or sensitivity test because the whole pulp chamber is filled with a bioceramic and restorative material. So we are based on the follow-ups radiographically, and of course the function or the subjective findings that we can see from the patient. The most important part, in my opinion, for follow-up these cases is the integrity of the coronal seal, because especially in young patients, they can miss a broken filling, and any break in the coronal restoration might lead to failure later on. We can say that it is a delayed failure of the procedure, not because of the procedure itself, but because of the coronal seal. So more than just taking an X-ray and making sure that the patient is functioning well, is to examine periodically the integrity of the restoration. And if the patient is having a high caries index or a risk for caries, that tooth might be later covered in order to avoid any problem with just a coronal direct restoration.
Yeah.
So we have satisfactory outcomes as long as the patient understand what we are doing.
Yeah. But it's very important to understand that sometimes in these teeth you cannot rely on pulse sensitivity tests, because of course maybe a young colleague could say, okay, I do the cold test, the tooth is not responding, I do the treatment. No, because of course the response is completely different from a regular tooth.
Yeah, the keys to success, we can consider this as a summary for all what we have discussed in the previous episode and this episode. So the first key and the most important key to success is the diagnosis and case selection, and to know which procedure that we need to do in that case. So this is very important to classify my case and to know the prognosis. And more important than to me is for the patient, because the patient has to understand that we are doing a different type of treatment, and he has to know all the aspect and all the details, because uh, if that patient went to other colleague and he just do an x-ray on that tooth and file just a restoration or a filling in the pulp chamber, if the patient is not aware of what has been done, the colleague might think that this is a partial treatment, like the pulpotecting and those dressings that are supposed to be not a complete treatment. So the patient must be aware of the procedure. The second most important thing to success is the complete isolation, because we need to just prevent any bacterial percolation into the root canal system. Otherwise, failure will be the only result. Third is the proper material selection. And we talked about the merits of using calcium silicates or bioceramics over calcium hydroxide. And we have to move from calcium hydroxide to those calcium silicate based materials. Coronal seal is very important because it leads to long-term success of VPT cases, and of course regular follow-up just to monitor any change in the bone around the tooth or even a change in the coronal restoration. I think by these five keys to success, if you follow it up in every step, these keys, I think you can reach a successful outcome. And maybe we can say now we have summarized the vital pulp therapy in every aspect, aren't we?
Yeah, I think so. I think so. But if you guys have some questions or you want something to be clarified, just write us and we will try to answer. Thank you very much for following Endocast and stay tuned for the next episode. Bye!
Bye.